This is an IVUS case illustration of a plaque rupture. A 70-year-old asymptomatic male was admitted to the hospital based on findings from coronary computed tomography angiography that showed a significant stenosis in the proximal left anterior descending artery. His only coronary risk factor was hypertension. The coronary angiogram shows a stenosis of approximately 70%, with an ulceration in the proximal LAD. On the left, the IVUS pullback was started from the middle of the LAD. From 6 o'clock to 12 o'clock, there is eccentric isoechoic plaque. There is a cavity inside of the plaque with hyperechoic static blood and hypoechoic retained contrast inside the cavity, and a residual fibrous cap separates the cavity from true lumen. These are illustrated in the still images on the right. The residual lumen is shown in green and the fibrous cap is shown in blue. Within the ruptured plaque cavity, there is hyperechoic static blood shown in yellow and retained contrast shown in orange. These still frames summarize the IVUS findings from the proximal LAD on the left to the mid-LAD shown on the right. The green area indicates the true lumen, the yellow area indicates the cavity that is occupied by static blood, the orange area indicates the cavity that contains retained contrast, and the blue area indicates the residual fibrous cap. We will now repeat the IVUS pullback. For comparison, this IVUS study of a ruptured plaque uses a 20 MHz solid-state device. During the pullback that is shown on the left, there is a ruptured plaque from 4 o'clock to 8 o'clock. The still images on the right illustrate the ruptured plaque cavity shown in yellow, the residual fibrous cap shown in blue, and the lumen shown in green. Compared to a 45 MHz IVUS, there is less blood speckle, and therefore the cavity is more distinct. From autopsy studies, the reported causes of acute coronary thrombosis include plaque rupture in approximately 55 to 60%, plaque erosion in approximately 30 to 35%, and calcified nodule in approximately 2 to 7%. Plaque ruptures can be observed in patients with myocardial infarction, unstable angina, or even stable angina and without symptoms.